This is endovascular embolization for a small ruptured frontoparietal AVM, grade 1, with NBCA. The patient is a 65-year-old male who presented with acute left hemiparesis. His hemiparesis was grade 3 out of 5. Intracerebral hemorrhage was noted in the right frontoparietal region with minimal mass effect. CTA was concerning for a possible arteriovenous malformation. As can be noted on these axial CT, the hyperdensity with the edema and the spot sign on the CTA suggest a possible either active source of bleeding or an underlying arteriovenous malformation or fistula. Here, a 6 French guide catheter is being introduced through a 6 French sheath up the dorsal aorta to selectively catheterize the right common, followed by right internal carotid artery, and in very delayed images one can see small distal ACA and MCA pedicles supplying a very small AVM. The ACA is initially catheterized with a microcatheter and 014 wire, and that microcatheter is then progressively advanced, as can be noted here, into the likely enlarged callosum marginal branch, all the way close to where the fistula arises, and one can note the location of the microcatheter. However, no obvious early venous drainage is noted, and therefore the microcatheter is withdrawn. Now it's used to selectively catheterize the right middle cerebral artery, the superior trunk, and the wire and microcatheter are advanced in tandem using roadmap, and a microinjection is performed which reveals the residual supply to the AVM primarily deep inside a sulcus, as demonstrated through a U on the lateral image, and draining into an early draining vein. Further microinjections clearly reveal the path to this AVM, which remains severely tortuous. This is a testament to the improved navigability and trackability of microcatheters to be able to make these transitions. Gradually the wire is advanced, and over the wire the microcatheter is advanced till we are essentially at the level of the nidus. Once at the level of the nidus, a microinjection clearly demonstrates evidence of AVM which is larger than one would have anticipated based on the original angiography. At this point, NBCA is prepared. The microcatheter is disconnected and flushed with dextrose water, and dextrose water is used to prep the catheter, and diluted glue is now being advanced from the microcatheter in a wedged position into the AVM nidus, and one can see very clearly excellent delivery of the embolic material into both the nidus as well as other collateral channels which have been supplying it. The nidus continues to fill, and at this point microcatheter is removed from the patient, and angiogram reveals complete obliteration of the AVM. In fact, one can note the occlusion through collaterals of the distal supply coming from the callosum marginal that was previously catheterized as well. High power magnification also again continued to reveal complete obliteration of previously noted AVM.